Welcome to the deep dive. We're here to take those dense clinical sources and really break them down into knowledge you can use. Today, we're tackling a really tough area in obstetrics, bleeding in early pregnancy, and some of the complex conditions linked to it. Our goal isn't just surface-level definitions, things like miscarriage, ectopic pregnancy, gestational trophoblastic disease. We want to go deep, understand the why behind them, connect the clinical signs to the diagnostic data, and really get a handle on how the experts manage these situations. This is about getting to that elite, professional level of understanding.
Exactly. And we're basing this on solid textbook-level clinical material. First things first, though, when we talk about bleeding in those initial 20 weeks, it really helps to think about it in two main buckets. Getting that initial split right helps guide everything else.
Okay, that sounds like a crucial starting point. Let's unpack that distinction. What are these two broad categories?
So category 1 is bleeding that's related to the pregnant state itself. This is the vast majority, maybe 95% of the cases you'll encounter. Think spontaneous abortion, ectopic pregnancy, hydatidiform mole, even simple implantation bleeding fits in here.
Got it. So conditions directly stemming from the pregnancy. What's category 2 then?
Category 2 is bleeding associated with the pregnancy but not caused by it. These are other issues, maybe cervical problems like ectopi or polyps, sometimes even malignancy that just happen to be there or get worse because of the pregnancy changes. The bleeding isn't from the pregnancy itself usually. But yeah, our focus today is really on that complicated 95% where the pregnancy itself is the issue.
All right, let's dive into spontaneous abortion, or as it's often called now, spontaneous miscarriage. Clinically, what's the line? When does it stop being a miscarriage and become a later fetal loss?
We generally follow the World Health Organization definition. Abortion is the expulsion or extraction of an embryo or fetus weighing 500 grams or less. That weight typically corresponds to about 22 weeks gestation or 154 days. Anything before that point is considered an abortus.
And you said this is a huge part of early bleeding issues. Just how common are we talking?
It's incredibly common. Estimates are between 10 and 20% of all clinically recognized pregnancies end in miscarriage. And the timing is really key here. About 3/4, 75% happen before the 16th week.
Wow, 3/4 before 16 weeks.
And of those, 80% happen before the 12th week. So overwhelmingly, miscarriage is a first trimester event, which, immediately points towards issues like chromosomal problems or early implantation failures being major players.
Okay, this leads us to the really complex part, the why. For someone aiming for that mastery level, what's the full list of factors that can cause a pregnancy to fail early on?
It's often a puzzle, honestly, and frequently it's not just one thing, but we group the causes into these main clinical buckets. First, and most common, are genetic factors. Then you have endocrine and metabolic issues. Third, problems with anatomy, so cervicuterine factors. Then there's infection, immunological disorders, thrombophilus, environmental factors too. And importantly, there's always a large group that remains completely unexplained. Understanding each of these is key.
Let's start with genetics then, since you said that's the biggest piece of the puzzle for early loss. What percentage are we talking about?
Right, for those early losses before 12 weeks, about 50% are thought to be due to a chromosomal abnormality in the conceptus itself. It's the single biggest known cause. When you look closer at those abnormalities, it's quite striking. Autosomal trisomy, having an extra non-sex chromosome, makes up half of all the cited genetic issues found.
Half are trisomies. Wow. Are there specific ones that are more common?
Definitely. Trisomy 16 is the most frequent single trisomy found, making up about 30% of those trisomy cases. But here's a really important detail, especially for interpreting test results. The single most common specific chromosomal abnormality overall isn't a trisomy, it's monosomy X, the 45, X karyotype. That accounts for about 20% of all genetically abnormal losses.
That's a critical point. Monosomy X is the single biggest specific genetic issue. What about having whole extra sets of chromosomes?
That's called polyploidy. It accounts for maybe 22% of these losses. So you might see triploidy, where there are 3 copies of every chromosome that's 3n equals 69, which is much more common than tetraploidy, or 4n equals 92. And then structural issues like parts of chromosomes being moved around, deleted, inverted, those account for a smaller slice, maybe 2 to 4%.
Okay, moving from the genes to the body's chemistry, what about endocrine and metabolic factors? You said 10–15%. What's the mechanism?
Yeah, the classic issue here is the pregnancy not getting enough support, particularly involving something called luteal phase defect, or LPD. This means either the corpus luteum isn't making enough progesterone, or maybe the endometrium isn't responding properly to the progesterone that is there. Either way, implantation and early placental development suffer. We also see links with really poorly controlled diabetes mellitus or significant thyroid problems, both hypothyroidism and hyperthyroidism. And thyroid autoantibodies are a big red flag too, sometimes even before the thyroid function tests are clearly abnormal.
Right. Now let's talk structure, the anatomical abnormalities. These tend to cause problems a bit later, more in the mid-trimester.
That's generally true, yes. These account for a pretty wide range in studies, maybe 3 to 38%, especially in cases of recurrent loss. A key one here is cervical incompetence, basically. The cervix isn't strong enough to hold the pregnancy. This could be something someone's born with, or it can be acquired maybe after procedures like a D&C that damage the cervix.
And what about congenital uterine shapes, like a bicornuate or septate uterus? How exactly do they cause problems?
There are a few ways they interfere. A septate uterus, for example, just means less usable space inside for the baby to grow. The uterine wall might not stretch as well either. Critically, if the placenta tries to implant on that septum, the blood supply is often poor, leading to failure. And these abnormally shaped uteruses can just be more irritable, more prone to contracting and expelling the pregnancy early.
Makes sense. And physical blockages like fibroids or adhesions.
Yep, especially submucous fibroids, the ones bulging into the cavity, they can really distort things and block implantation. They might also affect blood supply locally or cause pain if they degenerate. Then you have intrauterine adhesions, also called synechia or Asherman syndrome. That's essentially scar tissue inside the uterus, which can physically prevent implantation or proper placental development, depending on how bad the scarring is.
Okay, let's switch gears to infections. About 5%, you said.
Yeah.
And you mentioned something specific about spirochetes before 20 weeks.
Right, infections are about 5%. We worry about viruses like rubella, cytomegalovirus, HIV, parasites like toxoplasma, malaria, and bacteria like ureaplasma, chlamydia, brucella. The point about spirochetes like the one causing syphilis is interesting. Early in pregnancy, the placental barrier is quite thick, and it seems to effectively block them, so they rarely cause miscarriage before 20 weeks. Later on, as the barrier thins, they become a much bigger risk for congenital infection and late fetal loss.
Fascinating. Now, the immune system, always complex. Antiphospholipid antibody syndrome, APAS, that's a big one in immunological losses, right? Explain how that works.
Yes, APAS accounts for maybe 5 to 10% of immunological losses. It involves these autoantibodies, things like lupus anticoagulant, anticardiolipid antibodies, beta-glycoprotein-1 antibodies. The key thing to understand is that it's not really the body directly rejecting the fetus. The end result is fetal hypoxia, lack of oxygen, due to placental failure.
Okay, so how do the antibodies cause that hypoxia? What's the chain of events?
It's like a multi-pronged attack. The antibodies interfere with the trophoblast cells, which are crucial for early placental development. They activate the complement system, causing inflammation right there at the implantation site. They trigger the release of damaging inflammatory cytokines. And maybe most importantly, they cause thrombosis blood clots to form in those tiny vessels of the uteroplacental bed. That chokes off the blood supply, causes placental infarcts, and ultimately leads to miscarriage.
And that idea about the immune response balance T helper 1 versus T helper 2 you mentioned that underpins some therapies. Can you simplify that?
Think of it like this. Th2 is the peacekeeping immune response. It's anti-inflammatory, producing things like interleukin 4, 6, and 10. A successful pregnancy needs the immune system to shift towards this Th2 state. Ta1, on the other hand, is the warfare response that's pro-inflammatory, with cytokines like interleukin 2, interferon, and tumor necrosis factor. In recurrent miscarriage, you often see a dominance of this Th1 response. So when we use therapies like progesterone, one of the goals is to try and nudge the immune system back towards that protective anti-inflammatory Th2 state.
That makes sense. Okay, rounding out the causes, what else is on the list, and just how big is that unexplained category?
Well, there are inherited thrombophilus conditions like protein C resistance or factor V Leiden mutation, which also increase clotting risk in the placenta. Then, environmental factors. Heavy alcohol use, smoking, certain chemicals like lead or arsenic. High-dose X-ray exposure is a theoretical risk, but generally exposure under 10 rad is considered low risk.
But the really humbling part is the unexplained category. Even after going through all of this genetics, hormones, anatomy, infections, immune issues, thrombophilus, somewhere between 40 and 60% of recurrent miscarriages still have no identifiable cause. That's a huge number. It really highlights the limits of our current understanding and stresses the importance of supportive care.
Yeah, that 40 to 60% unexplained is really sobering. Okay, let's shift from the why to the what happens to clinical presentation. Can you quickly outline how the actual expulsion process differs depending on how far along the pregnancy is? Sure, the mechanism really shapes what you see clinically. very early, before 8 weeks, the whole ovum might come out intact, kind of like a small sac. Between 8 and 14 weeks, it's more common for the fetus to be expelled first, but the placenta and membranes get left behind, which often leads to an incomplete miscarriage. Then, beyond 14 weeks, it tends to happen more like a mini labor. The fetus comes out, and then the placenta follows sometime later. And there's a rare type called cervical miscarriage, where everything gets stuck in the cervix itself.
Okay, let's get into the clinical types, starting with threatened miscarriage. The name suggests it's started, but maybe it can still recover.
Exactly. In a threatened miscarriage, you typically see slight vaginal bleeding, could be reddish or brownish, maybe some mild backache, but often not much pain. The crucial finding on exam is that the external cervical os is closed, and the uterus size feels about right for the dates. The whole game here is figuring out if the pregnancy is still viable.
So how do you confirm that viability? What are the key tools?
Transvaginal sonography, or TVS, is essential. If you see fetal cardiac motion, that's great news. There's about a 98% chance the pregnancy will continue. On the other hand, if you see what's called an embryonic sac, basically a gestational sac that's 25 millimeters or bigger, but has no visible embryo that confirms it's not viable. We also use serum progesterone levels. A level over 25 nanograms per milliliter strongly suggests viability, like 95% confidence.
What's the management strategy, and what should patients know about the outlook?
Management is mainly supportive. Bed rest used to be common advice, but there's not much evidence for prolonged rest. Maybe just briefly until any active bleeding settles. Diazepam might be used if there's significant cramping or anxiety. Progesterone supplementation is often given, partly for that potential immune modulating effect, trying to encourage the Th2 response. As for prognosis, about 2/3 will go on to carry past 28 weeks. But it's important to counsel them that even if it continues, there's a slightly increased risk later on for things like preterm labor, placenta previa, growth restriction, even fetal anomalies.
Okay, next is inevitable miscarriage. This is when things have gone too far to stop, right? What changes clinically?
Right, inevitable means it's going to happen. Clinically, you see two main changes. The pain usually gets worse, often becoming crampy or colicky, and the bleeding increases significantly. The definitive sign on examination is that the internal cervical os is dilated, and you can often feel or even see the products of conception coming through it.
How do you manage that depending on whether it's before or after 12 weeks?
The goal is basically to help the process along safely and ensure everything comes out. Before 12 weeks, you'd typically evacuate the uterus, either with dilatation and evacuation D&E or suction evacuation. After 12 weeks, it's more like inducing that mini labor, often using an oxytocin drip to stimulate contractions, and then making sure the placenta and membranes are completely removed afterwards.
Then there's complete miscarriage, where everything comes out all at once. What's the main focus there?
Usually when it's complete, the patient feels a lot better quite quickly. The pain stops, bleeding slows right down, the os closes up, and the uterus feels smaller and firmer. Management is mostly about confirming it is complete. A TVS can show an empty uterine cavity. If it's empty, usually no further action is needed, except for one crucial step, checking the patient's rhesus blood type. If she's Rh negative and hasn't been sensitized, she absolutely needs anti-gamma globulin within 72 hours to prevent future problems. The dose varies a bit based on gestation.
Right, Rogam. Okay, the opposite scenario is incomplete miscarriage. You said this is the most common reason for hospitalization. What's happening here?
Yeah, incomplete means part of the pregnancy tissue, usually placental bits and membranes, is still inside the uterus. So the patient keeps having pain and bleeding, often quite heavily, and the cervix stays open or patulous. Ultrasound confirms there's echogenic material that's retained products of conception, or ERPC, still in the cavity. The big risks here are hemorrhage, which can be really severe, and infection, or sepsis. Sometimes a retained piece can form a placental polyp later on.
How do you get those retained products out? Sounds like there are medical and surgical options now.
Correct. You need to perform an evacuation of retained products of conception, or ERPC. Surgically, this is done with D&E, maybe using ovum forceps or suction. But increasingly, especially if the patient is stable and there isn't a huge amount retained, medical management is a good option. This usually involves using misoprostol, maybe 200 micrograms vaginally every few hours. It causes the uterus to contract and expel the remaining tissue. Medical management often has fewer potential long-term complications than surgery.
Lastly, for this category, miscarriage. This is where the fetus has died but hasn't been expelled yet. How does this present differently?
It's often much more subtle. Patients might notice a persistent brownish vaginal discharge, not necessarily heavy bleeding. A key symptom they often report is that their pregnancy symptoms like nausea or breast tenderness have faded or disappeared. The uterus stops growing, or might even feel smaller than expected for dates. Of course, there are no fetal heart sounds, and sometimes even standard urine pregnancy tests can become negative because the HCG levels drop.
If the uterus size is around 12 weeks or less, what are the management choices?
There are basically three routes. First, expectant management, just waiting. A lot of women, maybe up to 70%, will eventually expel everything spontaneously within a few weeks. Second, medical management, usually with a higher dose of misoprostol, like 800 micrograms vaginally, sometimes repeated. This often works within a day or two. Third, surgical management with suction evacuation, which might be preferred by the patient or if the medical approach doesn't work.
Okay, let's turn to septic abortion. This sounds like the real danger zone in early pregnancy loss, potentially very serious. What are the clinical signs that define it?
Absolutely. Septic abortion is a major crisis. It's basically any abortion complicated by infection in the uterus and its contents. The clinical definition usually involves a fever of 100.4 degrees Fahrenheit, that's 38 Celsius, or higher for 24 hours or more, and obviously infected or foul-smelling vaginal discharge, and pelvic pain or tenderness.
Where does the infection usually come from, and what bugs are we most worried about?
It's almost always what we call endogenous, meaning bacteria that normally live in the vagina travel up into the uterus. The danger comes from the mix of organisms you can get. Aerobes like E. coli, Klebsiella, group A strep, and really aggressive anaerobes like bacteroids and the one everyone fears, Clostridium loci, which can cause gas gangrene. Historically and clinically, septic abortion is strongly linked to unsafe abortions, often performed illegally without sterile technique, or where tissue is left behind, or there's injury.
There's a grading system, right? That seems crucial for figuring out how bad it is and how to treat it.
Yes, the grading is essential. Grade first is the most common. The infection is localized just within the uterus. This is often what you see after a spontaneous miscarriage becomes infected. Grade 2 means the infection has spread beyond the uterus into the surrounding tissues, the perimetrium, the tubes, ovaries, maybe the pelvic lining or peritoneum.
And grade 3, that sounds like the worst case scenario.
Grade 3 is the most severe, a true emergency. Here you have generalized peritonitis or signs of systemic collapse like endotoxic shock or acute renal failure. This level of severity is almost exclusively seen after unsafe induced abortions. The mortality rate historically could be as high as 20–25%, even with hospital care.
What are the catastrophic complications you see, mainly with grade 3?
They're systemic and life-threatening. Massive hemorrhage is common, sometimes worsened by injury to the uterus or bowel during whatever procedure was done. Endotoxic shock, often from E. coli or Clostridium welki, is a major killer. That shock state, especially with Welchia, can rapidly lead to acute renal failure, the kidneys shut down. You can also see severe lung problems like acute respiratory distress syndrome, ARDS, and the infection can spread through the bloodstream, causing thrombophlebitis, or clots in the veins.
Given how severe that is, what are the absolute core principles for managing any septic abortion?
There are 4 key principles you have to stick to. 1, control the sepsis with antibiotics immediately. 2, remove the source of the infection, which is the infected tissue in the uterus. 3, provide aggressive supportive therapy fluids, oxygen, whatever is needed to stabilize the patient. And 4, constantly monitor and assess how the patient is responding.
Okay, let's apply those. How do you manage grade 9?
For grade 1, you start broad-spectrum antibiotics right away. If there's any chance someone interfered with the pregnancy, you'd also give anti-gas gangrene and anti-tetanus prophylaxis. Then you need to evacuate the uterus to remove the infected tissue. But usually you wait about 24 hours after starting antibiotics to do the evacuation, unless there's really heavy bleeding that forces your hand sooner.
What about grade 2, where it's starting to spread?
Grade 6 needs more firepower. Powerful intravenous antibiotics, often multiple drugs combined, maybe something like piperacillin-tazobactam or carbapenem plus clindamycin to cover both aerobes and anaerobes. You monitor vital signs and urine output very closely. Here, you generally wait longer before evacuating, maybe 48 hours, to give the antibiotics a chance to contain the spread again, unless bleeding is uncontrolled. If an abscess forms in the pelvis, you might need to drain it, often via a procedure called posterior colpotomy.
And for the critically ill grade 3 patient?
Grade 3 is an ICU case, no question. The immediate focus shifts to aggressive supportive care managing shock, supporting breathing if needed, managing kidney failure with Mulvi fluids, maybe dialysis. Laparotomy, opening the abdomen, becomes necessary much quicker if the patient isn't responding, if you suspect injury, or if there might be a foreign object left inside. And this is where the really tough decisions come in. Often in grade 3, a hysterectomy is required to save the patient's life, even if she wanted more children, because removing the entire infected uterus is the only way to control the source.
Okay, let's transition now to recurrent miscarriage, or RM. What's the current standard definition for that?
The American Society for Reproductive Medicine, ASRM, defines recurrent miscarriage as 2 or more spontaneous losses before 20 weeks. It affects about 1% of women trying to conceive, and the pattern is worrying. After 3 losses in a row, the chance of the next pregnancy also miscarrying jumps up to over 30%.
When we look at recurrent loss happening in the first trimester, what are the main causes to focus on beyond the general list we already covered?
For recurrent first trimester loss, you really want to investigate parental chromosomal issues, specifically balanced translocations in one of the parents, though that's only found in about 3–5% of couples. Endocrine problems are important, especially polycystic ovary syndrome, PCOS, which seems to drive loss through insulin resistance and high insulin levels. Inherited thrombophilias like factor V Leiden pop up again because of that placental clotting risk. And of course, autoimmune conditions, especially antiphospholipid syndrome, APAS.
You mentioned alloimmunity, like HLA sharing is kind of inconclusive, but let's revisit that huge unexplained percentage, 40 to 60%.
Right, and that percentage really underscores why supportive care, sometimes called tender loving care or TLC, is so important in managing RM. It means that even after we run all the tests, genetics, hormones, immune panels for a large number of couples, we won't find a specific fixable cause. So, compassionate support and careful monitoring becomes central to their care.
Now, for recurrent losses happening later, in the second trimester, the focus shifts more to anatomy, right? Specifically, cervical incompetence. How is that diagnosed these days?
Exactly. Second trimester RM often points to structural problems. Cervical incompetence, or cervical insufficiency, is a major one. The diagnosis really relies heavily on the classic clinical history, a pattern of mid-trimester losses that are typically painless, often starting with membranes rupturing spontaneously, followed by painless expulsion of the fetus. While old tests like passing Hegar dilators are rarely used now, imaging is key. Ultrasound is the main tool. We look for a short cervix, usually defined as less than 25 millimeters long mid-trimester. And critically, we look for funneling of the internal os, where it starts to open up from the inside, looking like a Y, V, or U shape on the scan. Funneling over 1 centimeter is significant.
So how do you manage RM and cervical incompetence overall? Let's start with what can be done between pregnancies.
The time between pregnancies, the interconceptional period, is your chance to fix any identifiable structural issues. So if a woman has a uterine septum or adhesions, hysteroscopic surgery can remove them. A bicornuate uterus might occasionally be corrected with metroplasty. If parental chromosomal issues are found, genetic counseling is vital. For women with PCOS, getting their metabolic state optimized, often using metformin before they conceive, is important.
And once pregnancy occurs, what about treatments like progesterone or for APAs?
Once pregnancy is established, if there's a history of luteal phase defect or unexplained RM, progesterone supplementation is often used, maybe 100 milligrams vaginally daily, usually up to 10 or 12 once. The idea is partly hormonal support, partly trying to promote that helpful Th2 immune response. For women with confirmed APS, we have a standard effective treatment. Low-dose aspirin plus heparin, usually started early and continued throughout the pregnancy. Heparin is also the treatment for inherited thrombophilias during pregnancy.
And the surgical fix for cervical incompetence itself, the cerclage, can you explain the main types?
Right, the cerclage is basically a stitch placed around the cervix to reinforce it. It uses a strong, non-absorbable suture material like Merceline tape. Timing is important. A prophylactic cerclage is usually done electively around 14 weeks before the cervix starts to change. An emergency or rescue cerclage is done later if the cervix is already found to be dilated or shortened, trying to salvage the pregnancy. There are 2 main techniques you hear about. The McDonald cerclage is simpler and quicker. It's like a purse-string stitch placed around the cervix, high up but generally below the bladder reflection. The Shirod-Carr cerclage is a bit more involved. It requires making small incisions in the vaginal wall to dissect the bladder slightly upwards, allowing the stitch to be placed even higher, right around the level of the internal os, often burying the knot. Whichever method is used, the stitch must be removed around 37 weeks, or sooner if she goes into labor or membranes rupture.
Okay, let's shift gears now to discuss medical termination of pregnancy, or MTP. This is obviously guided by laws like India's 1971 Act, but the clinical reasons for considering it are pretty universal. What are the main indications?
The indications generally fall into three categories. First, therapeutic indications. These are rare now, but were historically used to save the mother's life if she had a very severe medical condition incompatible with pregnancy, like severe heart disease or malignant hypertension. Second, social indications, which probably cover most cases today. Unplanned pregnancy, contraceptive failure, or situations like pregnancy resulting from sexual assault. Third, eugenic indications. This is when there's a high risk the baby would be born with a serious physical or mental disability, perhaps due to major structural anomalies found on ultrasound, a known chromosomal problem, or exposure to harmful drugs or infections like rubella early on.
Let's break down the methods used based on the trimester, starting with the first trimester up to 12 weeks.
First trimester termination is generally the safest and has the most options. Medical methods are very effective, especially up to about 9 weeks or 63 days. The standard regimen is mifepristone, usually 200 milligrams orally followed 24 to 48 hours later by misoprostol, either 400 micrograms orally or 800 micrograms vaginally. It's highly successful. Surgical options include vacuum aspiration, using either a manual vacuum aspirator MVA or electric vacuum aspiration EVA. This is quick and very safe. Dilatation and evacuation, D&E, is also common, sometimes requiring the cervix to be prepared or ripened beforehand using osmotic dilators like laminaria tents or misoprostol.
Moving into the mid-trimester, 13 to 20 weeks, this gets riskier and more complex, right? What are the main medical approaches?
Yes, mid-trimester termination is definitely more challenging. The main medical strategy relies on using prostaglandins to make the uterus contract strongly enough to expel the pregnancy. Misoprostol is the most commonly used drug now, typically given in higher doses, like 400 to 800 micrograms vaginally or sometimes sublingually, repeated every few hours. A really important clinical point is that pretreatment with mifepristone, about 24 to 48 hours before starting the misoprostol, significantly shortens the time it takes and increases the success rate compared to using misoprostol alone. High-dose oxytocin infusions can also be used, sometimes in combination, but often aren't as effective on their own in the second trimester.
You mentioned historical methods like injecting hypertonic saline into the amniotic fluid. Why aren't those used much anymore? What were the dangers?
Those methods, like intraamniotic saline or urea, have largely been abandoned due to safety concerns and the availability of better options like misoprostol. They worked, but the risks were significant. Injecting concentrated saline, for instance, required great care to ensure it didn't accidentally go into the mother's bloodstream. If that happened, the consequences could be catastrophic: severe hypernatremia, high sodium, fluid overload leading to pulmonary edema, brain swelling, disseminated intravascular coagulation, DIC, and kidney failure. They were effective, but just too dangerous compared to modern methods.
Finally, what are the overall potential complications of MTP, especially highlighting the increased risk later in pregnancy?
Complications are significantly more common in the second trimester, maybe 5 times more frequent than in the first. Immediate risks include injury to the cervix or uterus, including perforation, hemorrhage, and infection, sometimes presenting as the post-abortal triad of pain, bleeding, and low-grade fever. Longer-term or remote complications are also a concern. These can include secondary infertility due to tubal blockage or uterine scarring, synechia, and importantly, an increased risk, maybe threefold, of having an ectopic pregnancy in the future. There's also a risk of developing cervical incompetence from the procedures, which could lead to mid-trimester losses in subsequent pregnancies.
All right, let's move to our next major topic, ectopic pregnancy, where implantation happens outside the uterine cavity. You mentioned incidence is up, but mortality is way down. What are the main things that increase someone's risk for this?
The fundamental issue is usually something that damages the fallopian tube or slows down the transport of the fertilized egg. The single biggest risk factor is a history of pelvic inflammatory disease, PID, or salpingitis, often caused by chlamydia trachomatis. Iatrogenic factors, things related to medical treatment, are also significant. For example, if a woman gets pregnant while using an intrauterine device, IUD, the relative risk of that pregnancy being ectopic is much higher, maybe 7 times higher. Failed tubal sterilization, especially certain types like bipolar coagulation, carries a high risk of subsequent ectopic pregnancy, sometimes 15 to 50%. And assisted reproductive technologies like IVF also increase the risk. About 5 to 7% of RT pregnancies might be ectopic, and there's about a 1% risk of heterotopic pregnancy, which is having both an intrauterine and an ectopic pregnancy simultaneously.
Pathologically, what actually happens inside the tube that makes it so prone to rupture?
The tube just isn't built for pregnancy. The key difference is the lack of a proper decidual reaction, that thick supportive lining you get in the uterus. Without that buffer layer, the invading trophoblast cells burrow directly into the muscular wall and blood vessels of the tube very quickly. This causes bleeding within the tube wall, stretching it, which causes the intermittent pain people feel. Eventually, the erosion goes right through the wall, causing it to rupture, often leading to massive bleeding into the abdomen.
And even though the pregnancy isn't in the uterus still undergoes some changes, right?
Yes, it does, because of the hormones produced by the ectopic pregnancy. The uterine lining, the endometrium, still thickens up into a decidua, just like in a normal pregnancy, but crucially, it doesn't contain any chorionic villi, placental tissue. When the hormone levels from the failing ectopic eventually drop, this entire decidual lining can sometimes be shed all in one piece, which is called a decidual cast. Microscopically, you might also see something called the Arias-Stellar reaction in the endometrial glands, which is just a specific change caused by the high progesterone levels.
Rupture sounds most dangerous in the narrower parts of the tube, like the isthmus or the interstitial section near the uterus. What's the classic triad of symptoms that should make you immediately think of a disturbed or ruptured ectopic?
The classic triad is abdominal pain that's present in virtually 100% of cases. Amenorrhea, or a missed period, is present in about 75%, and vaginal bleeding occurs in about 70%. The pain typically starts as crampy or intermittent as the tube stretches, then becomes sudden and severe if it ruptures. A really important symptom to ask about is shoulder tip pain. About a quarter of patients get this. It's referred pain caused by blood pooling under the diaphragm and irritating it.
Can you differentiate the main ways an ectopic pregnancy might present clinically? Acute, unruptured, and chronic.
Sure. The acute or ruptured ectopic is the dramatic emergency. The patient presents in shock, sudden severe pain, fast heart rate, low blood pressure, looking pale and unwell. Their abdomen is usually very tender and tense. And a critical point here, you should really minimize or avoid doing a pelvic exam in this situation because pressing on the area could potentially worsen the bleeding. The unruptured ectopic is often much more subtle and requires a high index of suspicion. The patient might just report a delayed period and some vague, one-sided pelvic discomfort. On exam, you might feel a small, tender, possibly pulsatile mass next to the uterus. The chronic or old ectopic happens when there's been slow, intermittent bleeding that forms a blood clot in the pelvis called a pelvic hematocele. These patients might have had symptoms for a while, often have a persistently elevated pulse rate, and you might feel a poorly defined, boggy, tender mass behind the uterus in the posterior fornix.
For that acute, unstable patient, diagnosis and action have to be incredibly fast.
Absolutely. If someone comes in clearly in shock from a suspected ruptured ectopic, you start resuscitation and prepare for laparotomy surgery at the same time. There's no time to waste on complex diagnostics beyond getting blood ready for transfusion, but for stable patients where you suspect an unruptured or chronic ectopic, we rely heavily on investigations.
Okay, let's define those key diagnostic markers. What's the crucial number for the beta-HCG level?
We use quantitative serum beta-HCG levels. In a stable patient, suspicion arises if the level is lower than expected for the gestational age, or if it fails to rise appropriately, it should roughly double every 48 hours in a healthy early pregnancy. But the single most important number is the discriminatory zone. This is generally accepted as a serum beta-HCG level of 1,500 international units per liter or higher.
Why is that 1,500 level so critical?
Because by the time the HCG level reaches 1,500, you should be able to see a gestational sac within the uterus on a transvaginal ultrasound, TVS, if it's a normal intrauterine pregnancy. So if the HCG is 1,500 or more and the TVS shows an empty uterus, the likelihood of an ectopic pregnancy is extremely high.
And what specific signs does the ultrasound look for outside the uterus?
TVS is looking for several things. Obviously, the empty uterus is key. Then finding free fluid, especially echogenic fluid, which suggests blood, in the pouch of Douglas behind the uterus. Seeing an adnexal mass separate from the ovary, sometimes called a blob sign, and a color Doppler ultrasound can be very helpful. It often shows a characteristic ring of fire pattern of increased blood flow around the ectopic implantation site. In places without easy access to ultrasound, an older test called culdocentesis, sticking a needle through the back of the vagina to see if you aspirate non-clotting blood, can still be useful. Blood with a hematocrit over 15% is highly suggestive.
Let's talk management for the unruptured tubal ectopic. There's been a big shift towards more conservative options,
A
right?
huge shift, yes. Expectant management, just watching and waiting, is really only an option in very select cases where the HCG is already low and falling, and the ectopic is very small, usually less than 4 centimeters. The main conservative approach now is medical management using systemic methotrexate, MTX.
What are the absolutely critical criteria that must be met to use methotrexate safely?
This is vital for patient safety. The criteria are strict. The patient must be hemodynamically stable. The initial beta-HCG levels should ideally be less than 3,000 IUL, though some protocols go up to 5,000. The ectopic mass size on ultrasound should be less than 4 centimeters. And, very importantly, there must be no fetal cardiac activity visible on the scan. If all these are met, the standard dose is usually a single intramuscular injection of methotrexate, 50 milligrams per square meter of body surface area. Then you have to monitor the HCG level weekly until it falls to undetectable, which usually takes several weeks.
And if medical management isn't suitable or fails, what's the preferred surgical approach now?
Laparoscopy is definitely preferred over open surgery whenever possible. If the goal is to preserve the tube for future fertility, the preferred conservative surgery is usually linear salpingotomy. You make a small cut over the ectopic, remove the pregnancy tissue, and usually leave the incision to heal on its own. If the ectopic is in the narrow isthmus part of the tube, segmental resection, removing just that damaged segment and potentially rejoining the ends later, might be better. Salpingectomy, which is removing the entire tube, is done if the tube is badly damaged, if the woman requests sterilization, or sometimes after a rupture.
Okay, moving on to our third major category of early pregnancy bleeding, gestational trophoblastic disease, or GTD. This is a whole spectrum of conditions involving abnormal growth of placental tissue. The malignant end is gestational trophoblastic neoplasia, GTN. Let's start with the most common form, the complete hydatidiform mole.
Right. A hydatidiform mole, or molar pregnancy, is technically a benign tumor of the chorionic villi, but it has a significant potential to become malignant, GTN. Pathologically, it looks like a mass of grape-like cysts or vesicles. This happens because the villi swell up with fluid, hydropic degeneration, and they lack fetal blood vessels. The complete mole has a very specific genetic origin. It's usually 46XX, but all the chromosomes come from the father. This happens through androgenesis. An empty egg gets fertilized by a sperm, which then duplicates its own chromosomes.
What are the clinical clues that might make you suspect a complete mole rather than a normal pregnancy or a typical miscarriage?
Vaginal bleeding is the most common symptom, maybe 90% of cases. But the really suggestive sign is often the uterine size. In about 70% of complete moles, the uterus is significantly larger than you'd expect for the gestational age because of all those proliferating vesicles. Patients might also have much more severe pregnancy symptoms like terrible nausea and vomiting, hyperemesis, and quite uniquely, they can develop signs of preeclampsia very early, sometimes even before 20 weeks. Occasionally, a patient might actually pass some of those grape-like vesicles, which is obviously diagnostic if seen.
How do you confirm the diagnosis? What are the key tests?
A very high quantitative beta-HCG level is a major clue, often way over 100,000 milli-international units per milliliter. And the transvaginal ultrasound is usually definitive. It shows the classic snowstorm appearance, the uterine cavity filled with mixed echogenic material representing the vesicles and blood clots, with no identifiable fetus or normal gestational sac.
How is a complete mole treated, and what's the crucial follow-up needed because of that cancer risk?
The standard treatment is suction evacuation, SE, to remove the molar tissue, regardless of how large the uterus is. For older women who have completed their family, hysterectomy might be an option, as it significantly reduces the risk, about 5-fold, of developing GTN later. After evacuation, the follow-up is absolutely mandatory and lasts for 1 year. This involves checking serum beta-HCG levels weekly until they become negative, which usually takes 4 to 8 weeks, and then monthly for the rest of the year. Reliable contraception is essential during this entire follow-up period to avoid confusion from a new pregnancy. Importantly, IUDs are usually avoided because they can cause bleeding that might mask recurrent disease.
How does that compare to a partial or incomplete mole?
The partial mole is quite different. The risk of it becoming malignant is much lower, less than 5%. Pathologically, only some of the villi are swollen, and there's often a fetus or amniotic sac present, although the fetus is usually abnormal and not viable. Genetically, partial moles are typically triploid, usually 69,000 XXY or 69,000 XY, meaning they have 1 set of maternal chromosomes and 2 sets of paternal chromosomes. The beta-HCG levels are usually only slightly elevated, not the extremely high levels seen in complete moles. Because the malignant risk is lower, the follow-up is usually shorter, maybe just 3 to 6 months after the HCG level returns to normal.
Can you briefly mention the placental site trophoblastic tumor, PSTT? It's rare.
Very rare, yes.
Yeah.
PSCT is different because it arises from a specific type of trophoblast cell called the intermediate trophoblast, found at the placental implantation site. It often presents with persistent irregular bleeding and low but detectable beta-HCG levels. A key point is that PSCT doesn't respond well to the chemotherapy usually used for GTN. Therefore, hysterectomy is generally the preferred treatment.
And finally, persistent GTN. This is when the molar pregnancy doesn't fully resolve or becomes malignant. How is that diagnosed and managed?
Right, persistent GTN occurs in about 15–20% of women after a complete mole. It's diagnosed if the beta-HCG levels don't fall as expected, if they plateau for several weeks, or if they start to rise again, usually checked around 8 weeks post-evacuation. Treatment depends on a risk score, often in the WHO prognostic score. Low-risk GTN is usually treated effectively with single-agent chemotherapy, most commonly methotrexate. High-risk GTN, which might involve metastases, longer time since pregnancy, or very high HCG levels, requires more intensive combination chemotherapy regimens.
We should also quickly cover some of the rare but potentially very dangerous ectopic locations. First, interstitial pregnancy implantation, right where the tube enters the uterine muscle. Why is that one so feared?
Interstitial pregnancy is the rarest tubal type, but it has the highest mortality if it ruptures. Because it's surrounded by uterine muscle, it can actually grow larger and for longer than other tubal ectopics, sometimes up to 12 or 14 weeks. But when it ruptures, the bleeding is catastrophic because it involves branches from both the uterine and ovarian arteries. On ultrasound, you see the sac located eccentrically within the uterine wall, right at the corner where the tube enters, often with only a very thin layer of myometrium, less than 5 millimeters surrounding it.
What about abdominal pregnancy? Usually secondary to a tubal rupture.
Yes, most abdominal pregnancies are thought to be secondary. The pregnancy initially implants in the tube, ruptures, and then reimplants somewhere in the abdominal cavity, on the bowel, omentum, or peritoneum. The key clinical finding in later abdominal pregnancy is often that the fetal parts feel incredibly easy to palpate through the abdominal wall, and the uterus feels separate and empty. Also, the patient won't have Braxton Hicks contractions. The risks are huge, massive hemorrhage at delivery, and very high rates of fetal malformation, maybe 50%, and fetal neonatal death, up to 90%. Management is urgent laparotomy. Often, the placenta has to be left behind if it's attached to vital organs, and its regression is monitored with HCG levels.
Cervical pregnancy implantation down in the cervix itself. What's the classic presentation?
Usually, painless vaginal bleeding is the main symptom. On examination, the cervix feels enlarged and kind of barrel-shaped. Ultrasound is key. It shows the gestational sac located entirely below the level of the internal cervical os within the cervical canal. There's also a negative sliding sign, meaning if you gently press on the sac with the ultrasound probe, it doesn't slide or move separately from the cervical tissue. Like interstitial pregnancy, this carries very high risk of massive hemorrhage.
And cesarean scar pregnancy, that seems to be recognized more often now.
Yes, definitely. This is implantation directly into the scar tissue from a previous C-section. Ultrasound is crucial for diagnosis. It shows the gestational sac embedded within the anterior uterine wall at the site of the scar niche, often with very thin or even absent myometrium between the sac and the bladder. This also carries a high risk of uterine rupture and severe hemorrhage, either spontaneously or during attempts at removal.
Lastly, heterotopic pregnancy, having both an intrauterine and an ectopic pregnancy at the same time.
This used to be extremely rare, but has become more common with the rise of assisted reproductive technology. It presents a real management dilemma because you want to treat the dangerous ectopic pregnancy while preserving the potentially viable intrauterine pregnancy, IUP. So systemic methotrexate is generally contraindicated if the IUP is viable. Management usually involves surgically removing the ectopic pregnancy, often laparoscopically, or sometimes targeted therapy like injecting potassium chloride directly into the ectopic sac while carefully monitoring the ongoing IUP. When you pull all these threads together, miscarriage types, ectopic locations, molar pregnancies, the mastery really comes down to integrating everything. It's about correlating those specific physical findings. Is the ISIT open or closed? What's the uterine size? What's the nature of the pain? with the sophisticated data we get from transvaginal ultrasound and those quantitative HCG levels.
That integration is absolutely key. And it feels like one of the biggest shifts, especially with ectopic pregnancy, has been this move towards conservative management, like using methotrexate for stable patients. But that entirely depends on rigorously applying those strict criteria, the right HCG level, the right size, no heartbeat. It really highlights how precise your clinical judgment needs to be.
Which brings us back to something quite profound. Even after mastering all these known causes, the genetics, the anatomy, the infections, the immune factors, we still end up with that huge percentage, 40 to 60%, of both spontaneous and recurrent miscarriages that remain utterly unexplained. That staggering number tells us that despite all our technology and detailed knowledge, the fundamental processes of successful implantation and early fetal development still hold major secrets. It's a clear call for continued focused research in reproductive science.